oversee their work through the steering group. So we're delighted that the Biobank are able to come and see us and speak to us today. We haven't been horrible to them yet, I don't think. So I'd like to welcome Assistant Professor and Research Fellow Eliana La Serda and her colleagues Shannae and Kate. Thank you.
Well, thank you very much. I'm delighted to be here. And after almost a decade ago, the first time that I came to speak to your group was when we were funded by the big lottery and doing some epidemiological research and the needs of people with ME/CFS in collaboration with, it was a collaboration between the London School of Hygiene and Tropical Medicine, the University of Hull, Faculty of Medicine, and in Norwich, the UEA. So today, from that decade ago, from now, we have been in a long path, and we were able to establish the first European disease-specific biobank dedicated to the study of the UK ME/CFS. So we are talking about accelerating the research, the global research in ME/CFS, because even our little group at the London School of Hygiene and Tropical Medicine, we were able to collaborate with different groups. And now I'm glad to say to you that we are heading collaborations across Europe with the EuroMIN group, European ME/CFS Network. We have 22 countries participating. Some of these countries have one doctor looking after ME/CFS patients, and the majority of the community don't know anything about ME/CFS. And we have some collaboration with colleagues in the US. Now our principal investigator is in Vancouver, Canada, heading a service of complex diseases, including ME/CFS. And I'm really glad to have two very talented young researchers, Kate and Shannae, that we were able to recruit, and this is our aim. So this is our team. We started, Louis and myself, Louis the PI, Dr. Louis Nacco, and we have the co-PI is Professor Hazel Dockrell. The top line is the clinical team. So we have Caroline Kingdom, who is our research fellow and research nurse and biobank coordinator. We have Jack Butterworth, that is our manager. Kate and Shannae, you'll be hearing today. And we have another research So this is our team at the London School. And what is a biobank? Do you have any idea of, when we speak about biobank, what a biobank is? No? Okay, so a biobank is a kind of repository that we collect biological samples. These can be saliva, urine, any fluid or tissue that we can store. In our case, we store blood samples, only blood samples at the moment. And then we can link these samples have assurance that the samples are collected with a good quality. So it's not collecting samples, put in a freezer, and that's it. We have to follow procedures to make sure that what we are seeing in the lab is actually something that is there. Is that an idea that you are following? Okay. So, another good thing about biobanks is that they are cost effective. For example, we have at the biobank at the moment, we have almost 600 participants. And to collect samples and data of all these participants, it took us almost 4 years. So what does it mean? It means that if I'm doing this research with this collection of samples at the London School, I have 4 years only for recruiting participants using the same protocols, and then I started looking at the samples in the lab and looking at the data, and then joining these and doing the analysis and taking the conclusions and getting the papers out for the scientific community. And in our case, we like to go back to the community of participants and show what we found. So it's a time consuming. If another group starts from scratch, they can use our samples, and these 4 years, they don't need to, because we have data, we have samples, and we can share with them in a cost recover basis to replenish our samples. So it's time effective and cost effective. And we can investigate different subgroups according to the data that we collect. Another thing that is very important is the basic science can formulate and test hypotheses. We can, with this, try to understand what is going on in the body milieu, and then we can even have a biomarker. So this is something that the biobanks in different settings can and have been helping with different diseases, human diseases, veterinary diseases, and other research as well. It's not going. Oh, yeah, sorry. So this seems quite scientific led, but this is some of the samples from the biobank. You don't see this because all the samples are anonymized, so we have a barcode for each participant. And we just put these pictures from the biobank just to illustrate where the samples have been stored in these big tanks with liquid nitrogen. They are conserved there and for future research. Okay, so how do we start this biobank? As soon as we finish our first research that I mentioned to you, we started thinking about a way to improve research, biomedical research in this area. And one of the main issues that we found was that, is a biobank feasible with this very small funding available, or almost no funding available for ME/CFS? And it is acceptable by the community of people with ME/CFS. So we decided to investigate this, funded by the main charities in the UK, and we developed research on the focus groups with people with ME/CFS, and we also consult experts on ethics about biobanks, human tissue banks, and law. And the main thing that we wanted to know was what was the reaction of people with ME/CFS. So we have a group of focus group with people with ME/CFS that were experienced their disease in a more kind of intimate way that we call lay patients. And we have people like you that has been advocating that we call expert patients. And I run these two focus groups with different people, not in terms of disease, but in terms of experience their disease. And then they told us what they think about. And one of the things that came out was that we have to ensure that the samples have good quality and they are linked to good data and relevant data. So this is some things that the patients with, the people with ME told us, that the samples have to be very good quality, we have to have appropriate information, and we have to have the right amount of information. So we collect a lot of data that the girls are speaking about this in response to this request, and also because we were sure, thank you, we were sure that this was the right way to do. Of course, there were some concerns, and one of them was mainly related to genetic material. And people were afraid that the government or even work agencies could get hold of their samples and could find that they have a specific disease, and this could be damaging for them. So in order to do that, to assure that we have to have some assurances of proposal to comply with. So initially, we submit the proposal to the IRAS, which is the Integrated Research Application System, that is the UK government that regulates all research that is done within the NHS. And we have the Research Ethics Committee that evaluate the research. In our case, is the London Bloomsbury Committee. And once we have the ethical approval from this body, we have to have the research governance approval for each area of the NHS that are overseeing the research done within the area. So, for example, the names are changing, but we have the East Coast that was looking after the research governance in the Norwich area. Then we also have to have our institutional approval. So we have the London School of Hygiene and Tropical Medicine Ethics Committee approval. Then for biobanking, we have to comply with the Human Tissue Act. And where the samples are, we have a Human Tissue Act license. So the way we managed to do with the small funding that we had at the time was to nest our biobank within already licensed biobank, which is the UCL Royal Free. including withdrawal of samples if they want their samples to be destroyed for any reason. And all the samples are de-identified. So when participants sign the consent form to us, they are assigned a code. And this code is for data, and we have another code assigned for the samples. So they are completely anonymized. So just to give you an idea what our consent form is. So we gave an information sheet in a Q&A format, and then the person has to say that they agreed, first of all, to confirm that they read and understood the information, then they consent for blood samples, donating blood samples, they consent to be clinically assessed by our research nurses or our clinical team. They consent that we use their clinical data, and they are aware that all the clinical data and the samples are anonymized, and they gave permission for us to use their aliquots of blood samples, and also they consent that we share these samples with ethically approved research. This means that if you donate blood to us and we store your blood, we use in our research, and a research from, say, Sheffield wants to use your samples, they submit a research proposal to the steering committee of the biobank, and we review this proposal. They have to be in line with our main purposes of the biobank, and they have to be ethically approved. So otherwise, we are not sharing your samples. We consider these samples very precious. And we respect these a lot. We respect all our participants that donate the time and the samples to us. So all the informed consent has been dated and signed by all participants. So, in a nutshell, we have established this biobank informed by experts in the field and also by people with ME/CFS, including people with severe symptoms. These samples can provide very good quality research. The biobank has to be relevant, feasible, ethical, and cost-effective, and I think that we ticked all these boxes. I'm not showing off, but I really believe in that, and I think that we are very proud of our achievements. We have SOPs, standard operation procedures, for all the recruitment and collection of samples, processing the samples, and up to the end of the researchers' users. So all these have to follow specific procedures that are written, and we are sharing our expertise with other biobanks around the world that are being formed. And we are open to ethically approved biomedical research. I think that now I pass to Shannae.
All right, so I'm just going to run you through a little bit about what our current study, what we do, and how we kind of define what we do. So we recruit cases that have to have a confirmed diagnosis, either by a GP or a specialist or consultant. And we use the Canadian and the Fukuda criteria to satisfy the diagnosis for the sake of our study. Not only that, but we have a bit of an age limit, so it has to be between 18 and 60 years. And this is the upper limit to this is purely because we're running immunological studies, and naturally after about 60 years the immune system starts to change, and so we want to be sure that the results that we're seeing in the blood in terms of immunology is reflective of the condition and not the actual age difference here. We tend to try and subcategorize our cases into two groups. This is a bit of a rough go at the moment because obviously there's no biomarker to specify severity. So we have a kind of mildly moderate, which tend to be people that are ambulatory, that some still work, some still can get out and about. And the other is the severely affected. So these tend to be people that are house or bedbound. One-fifth of a normal blood donation for those of you that have done that. So it's not too scary, and we've got some great nurses that like to make this as smooth as possible, this whole procedure. So when it comes to processing the samples, we take them to the biobank. A small amount is taken and sent for routine tests, and this is purely so that we can rule out any other possible causes of fatigue apart from ME/CFS. And then the rest of it is separated, it's spun down and divided into So these kinds of things include pain and fatigue scales. We ask them general health questionnaire, and then we've got a kind of phenotyping questionnaire as well, which asks them a lot about the symptoms that they're feeling and how severe they are, and other bits and pieces that give us this information. All right. So Eliana has already touched on this before, but any researchers that are requesting our samples must be working on a hypothesis. And that they're treating the samples with respect effectively and making sure that they're using them correctly. And then once all of this has been put in place, we can release the samples, be it the blood or the clinical data or both, but it's all been identified before anybody else gets their hands on it, and so there's no way of tracing that back to who's actually donated it. This is just to give you a bit of an example of where some of our samples and data have actually gone to. So we've worked in collaboration with some people, and other people have just requested it for their own stuff. So you can see United States, plenty of people in the United Kingdom, but as far afield as Israel and Brazil and Austria, so that's pretty exciting for us to see. All right, so in any given area of health research, there's a kind of logical path from conducting basic science and then eventually turning that into guidelines that are implemented into clinical practice and ultimately improving the health outcomes for people with that illness. So unfortunately, as I'm sure we're all very aware here, that in the case of ME/CFS, that this has been grossly under-researched and grossly under-resourced. And it's particularly more damaging when the guidelines are based off faulty science and adopted into clinical practice. So in terms of biobanks, this is where we feel like we can help out. Biobanks are generally situated in the perfect position to bridge basic science and clinical trials. The more resources we have, the bigger the studies can be. And it also allows for validation studies and to take place, which further strengthens the research area and the hypotheses coming out. So it's really important, and we really need this strong foundation in order to develop the best possible evidence-based guidelines and really make a positive change in people's lives.
Hi there. I'm going to talk to you a bit about the results that we've gotten since starting our biobank. So these are the main areas of research. Our group mostly sits within the clinical, the epidemiological, and the public health, and then we collaborate with people within the London School and abroad to fill these other gaps that we are not able to do ourselves. The direction in which we're traveling is we're finding more genetic environmental factors. We are searching for those clinical and molecular biomarkers. I think Eliana mentioned that we really would like to, we don't want to just find something biological, but we want to pair it with something that's clinical to make it a stronger diagnostic marker. And of course, the better diagnosis and better care and treatment for people with ME. So this is These are some quotes from people with ME. So we've asked them to help us interpret the results for the lay community as well as other patients. And these are some quotes that have come from it. So they've read through bits of our research. And this lovely woman, Dr. Penny Poulin, she was sitting in on one of our meetings, and I think it's called mind mapping or something like that. And she just, as we were speaking, she sat there and she was drawing and writing out what we were saying in a nice way that is it's very easy to read, and I feel like it has a big impact as well when you see this. So they've been very helpful with this. So how can we best serve people with ME? Our research is driven by the needs of patients and what research can do to address their needs. We carried out a review of personal stories that express the needs of people with ME. So the views of over 2,500 people with ME were analyzed, and what emerged was their need to gain a diagnosis, for the respect and empathy from service providers, and to develop strategies for better management. Gaining support from people with ME will depend more on the ability of researchers to understand and to respond to their specific needs. And we can do this by striving for better diagnosis and detection of reliable biomarkers, stratification of people with ME into categories related to severity, and effective treatment, as well as higher quality delivery of services. So services for ME/CFS need more availability and more coverage, as there are very few services covering a very limited geography here in the UK. And subgrouping to allow for better services targeted towards those who are more severely affected. To be able to do this, we need to have training. And we are planning on providing education and support in collaboration with other groups in the UK in order to do this. There is definitely a need for medical professionals to learn more about ME/CFS, and that comes from research. The short-form health survey is a 36-item patient-reported survey on the health-related quality of life. The answers from 8 distinct domains, considering physical and mental functions, are summarized into 2 component summary scores, the physical component summary score and the mental component summary score. Low scores indicate reduced functional status and reduced mental vitality. In addition, our symptoms assessment is comprised of symptoms that fit into clusters related to pain, neurocognitive, post-exertional malaise, neuroendocrine, sleep dysfunction, autonomic, and dysfunction, Here we see that for physical component summary, the symptom cluster that is the strongest predictor for reduced score is the post-exertional malaise in those who are mildly affected. And then for neuroendocrine, so what this means is the driving factor, the symptoms that are reducing the physical component summary score, are these particular symptoms. So these are and then in mental component summary score, we see that it's slightly different for the mild and moderate. They now sleep dysfunction is affecting their mental vitality, whereas again with those who are severely affected is their neuroendocrine symptoms. And then we see with healthy controls, it's pain and sleep dysfunction, which I think it could be that's understandable, I think. Well, many people suffer from sleep dysfunction. So this figure is a spider chart where axes radiate outwards from a central point, the 0, with each axis representing an SF36 scale or component summary score. The median scores found for the scales and component summaries in each group are plotted in the axes in the spider chart. A smaller polygon reflects a lower score, and a larger polygon reflects a higher score and therefore a better quality of life. By joining the points on the axis by group, the resulting polygons clearly displayed differences in scores from people with ME, people with MS, and healthy controls. And you'll see where they're most different is in social function, which is quite interesting, where they're most similar is in mental health. It's very telling. Shannae mentioned that we do the hand grip strength, and we've written a paper about this as well. We looked to see if hand grip strength could be used as a diagnostic marker So we had our people with ME patients, people with MS, and healthy controls. They did 3 successive trials of using the hand grip strength. And something that our nurse really noticed, which was interesting, is that as they were doing the trials, people with ME seemed to get worse. They seemed to have a lower grip strength as they were going through, which is really not seen for healthy controls in the blue, and those with MS. They seem to stay pretty stable. Even people who are mild, moderately affected, they have a slight decline, although they stay pretty steady towards the 3rd trial. We see a big difference for those who are severely affected. Looking at the maximum and minimum of the hand grip strength, here we have for healthy controls and MS, and the differences between their maximum and their minimum hand grip strength is very similar. There's not really much of a difference. Whereas here we see it for mild and moderately affected, and for those who are severely affected, there's quite a big difference there. So longitudinal analyses of these SF36 scores, they add to our understanding of the variation in health-related quality of change in outcome that would indicate a need to change a patient's management as well. So today we've talked to you about our biobank, which has been very exciting, about the robust protocols that we have and how cost-effective and time-effective it can be, how we share data, how we share samples, and how precious those samples and the data are to us, how we are open to opportunities for collaboration, and we're constantly seeking worldwide collaboration. And that the